Hello everyone, and welcome to our session on burn management for nurses. Today's lecture is presented by Dr. Abdikhani Ahmed Abdi. In this course, we will review the essential knowledge every nurse should understand when caring for burn patients, including early assessment, classification, fluid resuscitation, wound care, and ongoing monitoring. Our goal is to help you build a clear foundation and feel more confident when managing burn cases in your daily practice. In this session, we will cover 4 key topics. First, a brief introduction to burn injuries. Second, the different types of burns and how they present. Third, the rule of nines, which helps us estimate burn size and guide management. And finally, we will walk through the essential steps of burn management for nurses. Let's begin. Burn injury is one of the most common emergencies we face in both the ER and the ward. As nurses, our first role is to recognize the severity of the burn, provide immediate comfort, and prevent further tissue damage. In this session, we will start with a simple introduction to what a burn is, how it affects the skin layers, and why early nursing assessment is so important. Understanding these basics will help us provide faster, safer, and more effective care for our patients. A burn is an injury to the skin or deeper tissues caused by heat, chemicals, radiation, friction, or electricity. The severity of a burn depends on 3 major factors: the depth of the burn, the total body surface area involved, and the mechanism of injury. In the emergency room, about 22% of burn patients will require ICU admission because of the risk of airway injury, fluid shifts, and multi-organ complications. Now we are moving on to the types of burns. Before we look at each type in detail, remember that burns can vary widely depending on the cause, depth, and severity. Understanding the category of a burn helps nurses assess the patient faster and choose the right management plan. Let's take a closer look in the next slides. Burn injuries can be classified into 4 major types based on their etiology. The first type is thermal burns, caused by direct contact with heat sources such as fire, boiling water, hot surfaces, or steam. The second type is chemical burns, which occur when the skin is exposed to strong acids, alkalis, or other corrosive substances, commonly seen in industrial accidents or contact with cleaning agents. The third type is electrical burns, resulting from electrical current passing through the body. These burns often cause deeper tissue damage and may be associated with faulty wiring, lightning, or high-voltage exposure. The fourth type is radiation burns, which are less common and usually related to sunburn, radiation therapy, or occupational radiation exposure. Understanding these categories helps nurses quickly identify the cause and anticipate potential complications. Next, let's look at how the American Burn Association classifies burn severity. This system helps nurses decide how serious a burn injury is and when a patient needs higher-level care. Minor burns include partial thickness burns less than 10% TBSA or full thickness burns under 2%. These cases exclude burns involving critical areas such as the face, hands, feet, genitalia, or major joints. Moderate burns cover partial thickness burns between 10 and 20% TBSA and full thickness burns between 2 and 5%. These patients also should not have inhalational injuries or other major complications. Major burns are the most severe. This includes partial thickness burns greater than 20% TBSA, full thickness burns over 5%, and any burns involving the face, hands, feet, genitalia, or major joints. Electrical, chemical, and inhalational burns also fall into the major burn category. This classification guides triage, treatment decisions, and ICU admission. On this slide, we explain burn classification by depth. First-degree burns involve only the epidermis. The pain is moderate, the skin appears pink or red, and healing takes 5 to 10 days. Superficial, partial thickness second-degree burns involve the epidermis and superficial dermis. They are painful, show blisters, and usually heal in 2 to 3 weeks. Deep, partial thickness second-degree burns extend deeper into the dermis. Pain is minimal because nerve endings are damaged. These burns appear mottled and heal in more than 3 weeks. Third-degree, full-thickness burns involve the entire skin layer and subcutaneous tissue. There is no sensation due to nerve destruction. The skin looks leathery or charred, and surgical intervention is required. Healing takes more than 8 weeks. Next, we will look at the rule of nines. This is an important method used to estimate burn surface area. Let's continue to the next slide for more details. Now let's talk about the rule of nines. This method is used to estimate the total body surface area burned. Each major body region is assigned a percentage value. For example, the head and neck are 9%, each arm is 9%, the anterior and posterior trunk are 18% each, and each leg is 18%. This quick estimation is very important because it guides fluid resuscitation using the Parkland formula and helps determine whether a patient needs ICU admission. Here is the TBSA breakdown for adults. This table helps nurses quickly estimate the burn percentage of each body part. The head and neck together count as 9%. The anterior trunk is 18%, and the posterior trunk is another 18%. Each upper extremity is 9%, making both arms a total of 18%. Both lower extremities together account for 36%, or 18% for each leg. And finally, the perineum or groin accounts for 1%. This breakdown is essential when calculating total burn area and when preparing for fluid resuscitation. Next, we will move into the most important part of today's topic, burn management. In this section, we will focus on practical steps that nurses should follow from the moment a burn patient arrives, including initial assessment, wound care, and essential interventions. This slide explains the 3 major phases of burn injuries. Phase 1 is the emergent or resuscitative phase, usually the first 24 to 48 hours. During this period, our priority is stabilizing the patient, controlling life-threatening complications, and beginning fluid resuscitation. Phase 2 is the acute or wound healing phase. Here, the focus shifts to infection prevention, wound care, and supporting tissue repair. Phase 3 is the rehabilitative or restorative phase, where we work on long-term recovery, functional improvement, and minimizing disability. Now let's look at pre-hospital management, the actions performed before the patient reaches the hospital. First, the rescuer must ensure their own safety. Second, remove the patient from the source of injury. Stop the burning process as quickly as possible. Remove burning clothing, jewelry, watches, or belts to prevent swelling-related complications. Finally, pour ample clean water on the burned area, not ice or ice packs, because they can worsen tissue injury and cause hypothermia. Now let's quickly review the ABCDE primary survey for burn patients. A airway and C-spine check if the airway is open. If there are signs of inhalational injury, like soot or hoarseness, prepare early intubation. Protect the cervical spine. B. Breathing, check breathing and breath sounds. Look for problems like tension pneumothorax or massive hemothorax and manage immediately. C. Circulation, insert 2 large bore IVs and give isotonic fluids for hypotension. Use norepinephrine if vasopressors are needed. You may puncture burned skin if necessary, but avoid IVs in limbs with circumferential full-thickness burns. D. Disability, check consciousness. Consider CO or cyanide poisoning, especially in enclosed space fires. E. Exposure and environment, expose the patient fully but keep them warm. Remove clothing and jewelry. For chemical burns, irrigate with plenty of room temperature water. When deciding whether a burn patient requires ICU admission, we follow the ABA guidelines. Patients with more than 20% TBSA burns in adults, or more than 10% in children and the elderly, should be admitted due to the high risk of shock and complications. ICU care is also necessary when inhalational injury is suspected, especially after enclosed space fires. Any altered mental status, such as confusion or decreased consciousness, is another warning sign. Circumferential full-thickness burns, or signs of developing compartment syndrome, also require close monitoring. Finally, patients showing organ dysfunction or those with significant associated trauma need intensive care support to prevent deterioration. Inhalational thermal injury should be suspected in any patient exposed to closed space fires or showing signs such as soot around the mouth or nose, hoarseness, stridor, or loss of consciousness. Once suspected, we immediately provide high-flow 100% oxygen and monitor carboxyhemoglobin levels. Hyperbaric oxygen may be considered for severe carbon monoxide poisoning, and hydroxycobalamin is recommended when cyanide toxicity is a concern. Early intubation is important if airway edema is expected. Indications include any stridor, rapidly worsening edema within the first 24 to 48 hours, deep facial or intraoral burns, inability to clear secretions, respiratory distress, or declining consciousness. Extubation should generally be delayed for 48 to 72 hours until the airway is stable. For burn patients, fluid resuscitation is essential to prevent shock and maintain perfusion. The Parkland formula is the most commonly used method. For adults, we calculate 2 milliliters times body weight in kilograms, times the percentage of total body surface area burned. For children under 14, we use 3 milliliters times weight times TBSA, plus maintenance fluid. Ringer's lactate is the preferred solution. Half of the calculated volume is given in the first 8 hours from the time of injury, and the remaining half is given over the next 16 hours. We titrate the fluid based on urine output, our key indicator. For adults, the target is at least 0.5 milliliters per kilogram per hour, while children require at least 1 milliliter per kilogram per hour. We always adjust the fluid rate according to the patient's response. In wound care, our first priority is gentle but thorough cleaning. We remove debris, loose skin, and old exudate so the entire burn surface can be seen clearly. Warm saline, not cold or ice, is used to prevent further tissue injury. Appropriate topical antimicrobials, such as silver sulfadiazine or mefenide acetate, help reduce infection and support healing. Non-adherent dressings should be applied and checked every day for infection signs, including changes in color, odor, or the amount of exudate. For circumferential burns, we must closely watch for compartment syndrome and assess the 5 Ps: pain, pallor, pulselessness, paresthesia, and paralysis. If circulation is compromised, an escharotomy may be needed to restore blood flow. Pain in burn patients is intense and requires early, aggressive IV opioid management. We usually start with IV fentanyl or morphine and adjust the dose based on the patient's pain score and vital signs. Validated pain scales, such as the numeric rating scale or visual analog scale, help guide titration and ensure adequate analgesia. Continuous reassessment is essential. Some burn patients, especially those who are intubated, also need sedation to reduce anxiety, improve ventilator synchrony, and tolerate procedures. We use the RASS scale to guide sedation, aiming for a light sedation level around -1 to -2. Avoiding deeper sedation helps prevent complications and supports recovery. For anxiety, medications like midazolam or lorazepam may be used as needed. Psychological support is also important because pain, anxiety, and trauma often occur together in burn injuries. For wound care and nutrition in burn patients, we focus on 2 major areas. First, early enteral nutrition should begin within 6 to 12 hours when possible. We use a high-protein, high-calorie formula to counter the hypermetabolic response. Early feeding helps reduce infections, improves wound healing, and maintains gut integrity. Second, we follow strict infection control principles. This includes daily wound assessment, using sterile technique during dressing changes, and avoiding routine prophylactic antibiotics. We also monitor for warning signs such as tachycardia, fever, or delayed healing. Early excision of eschar can help reduce infection risk. All right, this is the end of today's session. Thank you for your attention and participation. If you have any questions, feel free to ask. I'm happy to explain anything again.